Good day, USRNs to be. Once again, this is your mentor, your fact check buddy, Gapuz, giving out the next cluster of topics that you need to focus on for you to be able to pass next generation NCLEX on your first try with a minimum number of items of 85. So welcome to our next gen NCLEX quick fix trend. So USRNs to be, are you ready? So this is your mentor, Gapuz, the author of NCLEX-RN in a Flash, published by Jones and Bartlett USA, joining you for this session. Before anything else, I'd like to share with you some snippets of testimonials given by passers from our bootcamp. So this was actually sent in a Filipino message. Okay din po, kasi care of newborn, toddlers, adult with visual problems, nasa simulation po natin. Same na same. Care of newborn, toddlers, adults at home po. That's what she's saying. So she had some topics related to care of newborns, toddlers at home. And the most significant thing here is that she saw it the same in our next gen simulator. Okay? Here's another one. From Roxa, Doc, pasadong-pasado po. I slayed at 85 questions and can confidently say I gave a very strong performance on my exams, all because of your help. The receta you gave me, well, the receta is actually a prescription I give the test takers on the month before they take the test. The receta you gave me prior to my exam helped me a lot. It was the last thing that I did before I took the test. Overall, it was the entire time spent with you during Compre, Bootcamp, and QUICKFIX that sealed the deal. Forever grateful to you, Doc Ray, for helping me achieve my dream na matagal kong kinalimutan. So she said she almost forgot about the dream and just realized some dreams are still worth chasing. We just need the right mentor who is generous enough to guide us every step of the way. You are truly God's gift to nurses, Doc Ray. I wish you a lifetime full of love, happiness, and health. Thank you so much. And we also have someone named Kay. Of course, that's not her real name. We have to cover the full name, okay, to protect their privacy. I asked, is our simulator helpful? And this is what she says. Thank you, sir. Super. And she says, nakatulong po yung simulator sa akin, sir. So that's what she said in Tagalog, that the simulator helped her a lot. Kasi niready niya ako mentally na kahit di ako nakapag-break sa 5 hours na exam, kinaya ko po kasi nasanay po ako sa simulator ng RAGRS. So that's what she's saying. She was able to develop the mindset to withstand a grueling 5-hour test. That is through the training she had with our simulator. And then I asked another, Ver, what do you like the most in our review system? And this is what he says in English. It gave me chills reading some questions in my exam, which we exactly discussed during the review. Amazing, sir. Once again, let me repeat that. It gave me chills reading some questions in my exam, which we exactly discussed during the review. Amazing, sir. So thank you very much for those kind words. If you want to avail of my prescription on what you need to study for the test, scan this QR code to get your free receta or prescription handouts. And of course, listen to the next topics which I put together from my previous video so that you don't have to search through our YouTube channel. Just play it, and please don't skip the ads because it goes to our scholarship program benefiting 500 nurses from different parts of the world. Thank you for believing in the Gapuz review system. Happy learning. Remember, watch the next set of concepts that I'm going to discuss in the next part of this video. Take care and God bless.
Asia Corporate Excellence and Sustainability Awards 2025. In the dynamic landscape of Asian business, one stage continues to shine as the pinnacle of recognition for leadership, innovation, and purpose-driven excellence. The Asia Corporate Excellence and Sustainability Awards 2025. Widely regarded as one of Asia's most prestigious and influential award-giving bodies. This annual celebration brings together the region's most visionary organizations, honoring those that set the bar in corporate performance, sustainability, and leadership impact. This year, the Philippines proudly stood tall among Asia's finest. Ayala Corporation, SM Malls, BDO or Globe Telecom, and San Miguel, some of the country's most respected institutions, were honored for their unwavering commitment to nation building, customer service, digital transformation, and sustainable business practices. Their recognition affirms the Philippines' growing presence as a hub of excellence within the Asian business community. Amid these corporate giants, one award was particularly groundbreaking.
There are individuals who outlive industries, empower communities, and redefine what purposeful leadership looks like across Asia. Their work inspires progress, strengthens institutions, and shapes the region's future with clarity, courage, and conviction. In this segment, we also recognize visionaries who are advancing innovation, elevating national capabilities, with driving positive change at scale. Their leadership reflects resilience, strategic foresight, and the unwavering commitment to excel. Tonight, we celebrate individuals whose achievements exemplify what it means to lead with purpose, with impact, and with integrity. To present the awards, it is with great pleasure to invite our honorary chairman of the ACES Awards, Mr. Hemant Batra, and president of the ACES Awards, Dr. Shigari Balakrishnan. Let's give them another big round. Welcome back, Mr. Hemant, Dr. Shigari. Hope you enjoyed the evening so far. That Shakira performance was outstanding indeed. Well, ladies and gentlemen, we begin the segment with the milestone moment as we introduce a brand new award category, the Emerging Leaders in Asia Award, which shines a spotlight on rising figures whose early leadership already reflects exceptional vision, discipline, and transformative potential. This year marks its inaugural presentation, and tonight, the very first recipient of this distinction is presented to Dr. Ricate Ray Gapuz, President and CEO and Academic Director, International Center for Advanced Review and Training, Inc. Congratulations. Dr. Ray is reshaping professional exams preparation for a global learner base. His visionary leadership blends technology, pedagogy, and innovation to make him high-quality, concept-driven learning accessible across borders. Dr. Ricate Ray Gapuz, President and CEO and Academic Director, International Center for Advanced Review and Training. Congratulations!
The recognition of Dr. Ray Gapuz as the Pioneer Awardee for Asia's Emerging Leaders. This distinction celebrates a visionary educator and entrepreneur whose work has reshaped the landscape of nursing, review, and advanced learning systems across the region. As the founder of the Ray Gapuz Review System, Dr. Gapuz has empowered generations of nurses across 36 countries, consistently delivering top-notches, global passes, and an unmatched culture of academic excellence. His award is more than a personal milestone, it is a testament to the excellence, innovation, and global impact of the Ray Gapuz Review System, proving that world-class leadership can thrive in education just as powerfully as in the corporate arena. Tonight, we celebrate not only Asia's greatest companies, but also the leaders who inspire transformation, those who prove that excellence is not an act, but a legacy in the making.
Our speaker holds a higher education teaching certificate from the Derek Bach Center for Teaching and Learning at Harvard Graduate School of Education, where he also obtained a training certificate in online facilitation. He is a member of Harvard Business Review Advisory Council and opt-in research community of business professionals. He finished a program on artificial intelligence from the University of Oxford. He finished his Master of Education and Learning, Design, and Technology and Post-Baccalaureate Certificate in E-Learning Design at the Pennsylvania State University, where he finished both courses with a GPA of 4.00. He completed his training on the ecosystem approach to designing and implementing outcomes-based education from the ASEAN University Network in Thailand. He finished his Bachelor of Science in Nursing cum laude and Master of Arts in Nursing summa cum laude at the University of Santo Tomas. He was a board top-notcher in the Philippine Nurse Licensure Examination, where he obtained a rating 89.20. He is a recipient of two doctorate degrees honoris causa from two state universities in the country, the Ramon Magsaysay Technological University and the Pangasinan State University. He co-authored a book on technology integration in teaching and learning entitled Collaborative Virtual Instructional Designs for Teaching and Learning Nursing. He is the author of NCLEX-RN in a Flash published by Jones and Bartlett, USA, and Mosby's Essential Concepts for the Philippine Nurse Licensure Exam published by Mosby Elsevier. He is the proponent of the Functional Concepts Method, a teaching pedagogy for international licensure exams. He is the inventor of several game-based apps and a consultant of various international firms and educational institutions. He is a multi-awarded entrepreneur and author. Among his numerous awards are the Manny V. Pangilinan MVP Bossing Award for Education, the SMEIT Award for Innovation from the Philippine Internet Commerce Society, the AGRA Award for Entrepreneurship from the Philippine Marketing Association, the 10 Outstanding Filipino Entrepreneurs Entrepreneur 10 from Entrepreneur Magazine, and the Young Market Master for Entrepreneurship from Mansmith and Fielders. He is also the first Filipino nurse entrepreneur to be accepted as part of the Ernst & Young Entrepreneur of the Year Academy. In 2005, he was named one of Go Negocio's first 50 inspiring Filipino entrepreneurs, and in 2006, the Philippine Graphics magazine's Young Leaders of the Philippines. Also in 2006, he was co-listed with Bill Gates in the 25th edition of Marquis Who's Who in the World. Currently, he serves as a trustee of the Philippine Center for Entrepreneurship PCE, an advocacy group under the Office of the President. Ladies and gentlemen, Dr. Ray A. Gapuz.
Let's begin with our next generation NCLEX-RN case number 14, and this is about cystic fibrosis. Now, we know for a fact that cystic fibrosis has a genetic basis and it's a multi-system disease. Now, on to our concepts related to cystic fibrosis. As I've been telling you a while back, it is an inherited condition, and the pattern of inheritance is through autosomal recessive pattern. Now, what does that mean? Now, remember, if a condition is transmitted through an autosomal recessive pattern, both parents have to be trait carriers so that their child will have a 25% chance of having the disease and 50% chance of becoming a trait carrier. What does that mean? So if there's only one parent who is a trait carrier, that simply means that there's just a 50% chance of transferring the trait to the child. So there's no chance that the child will have a disease if only one parent has the trait. But if both parents have the trait, there's 25% chance of having the disease for the child and 50% chance of the child becoming a trait carrier. So take note, for autosomal recessive pattern, for a child to have the disease and for the child to have a 25% chance of having the disease, both parents must be trait carriers. So if only one parent is a trait carrier, the chance is just for the parents to transfer the trait, not the disease. Okay, so it's important also to note that since this is a genetically transmitted condition, then you need to refer the parents to a geneticist so they will be able to understand how they can potentially transmit the condition to their children. So cystic fibrosis can be manifested by, remember, A, B, C, D, E, F. So altered growth, this could be associated with malabsorption of nutrients, breathing difficulty because of the obstruction of the airways by thick mucus, coughing and constipation, digestive enzyme blockage that could result to the presence of foul-smelling greasy stools. There will be exercise intolerance because the airways are usually obstructed with thick mucus, and of course, foul-smelling greasy stools. Okay. Now, cystic fibrosis is tested through your IRT, your immunoreactive trypsinogen. That's usually done as part of the screening process in babies, but this is not confirmatory of the disease. Now, what confirms the disease would be your genetic testing. So cystic fibrosis is treated with pancreatic enzyme replacement therapy. Example, they will give pancreolipase. This should be given with each meal and snack, which simply means that every time the child eats, they have to be given pancreolipase. That would facilitate the digestion of fats. And take note, since children with cystic fibrosis may have difficulty absorbing fats, their diet should be high fat, high calorie, and high sodium. Why high fat? Because you need to replace the fats that they have excreted through their stools, okay, so that their body can make use of the fats, specifically for functions like the conversion of your fat-soluble vitamins into more absorbable forms, okay? And then, of course, your cystic fibrosis, transmembrane conductance regulator modulator. That's a lot of things to remember. So remember ivacaftor. So drugs that usually ends with a caftor are with a suffix caftor are usually, more often than not, used for the treatment or management of cystic fibrosis. Okay, so let's apply what we just learned to a case study. This is case number 14. The parents of a 6-month-old child comes to the clinic for a follow-up visit. The mother of the child tells the nurse that their child had been diagnosed with cystic fibrosis. So which statement made by the mother reflects a need for the nurse to refer the couple to a geneticist to promote understanding about the disease transmission. Now, the first thing that you have to do before we move on and discuss the options is for you to analyze and think about what the question is asking. So pay particular attention to the phrase need for the nurse to refer the couple to a geneticist to promote understanding about the disease transmission, which simply means you are supposed to look for a statement that may not be true in relation to the genetic transmission of the condition, because you have a phrase reflects a need for the nurse to refer the couple to a geneticist to promote understanding. So the question is implying that the couple whose child has cystic fibrosis may not have adequate understanding regarding the transmission of the disease. So let's move on. Is it one? Since my husband and I are trait carriers, our baby have a 25% chance of having the disease. Well, we said a while back that cystic fibrosis is transmitted through autosomal recessive pattern. And if both parents are trait carriers, there's a 25% chance of the child having the disease. So one is correct. That is not something that you need to clarify with the geneticist. Okay, so two, both of us are carriers of the trait, so our child will have 50% chance of having being a carrier too. Yes, that doesn't need to be clarified with the geneticist. So remember, we're looking for a statement that you need to clarify with the geneticist. So just to summarize the first two statements, if a couple are both carriers, therefore, the transmission of the disease is at 25%. Now, if the couple are both trait carriers, if the question is about transmitting the trait, then it's 50%. So if the question is about disease transmission for both couples who are trait carriers, the answer would be 25%. If the question is about trait transmission for a couple who are both trait carriers, then the answer is 50% chance. Once again, 25% chance for disease transmission, if that's what the question is asking, 50% chance for trait transmission, if that's what the question is asking. So 1 and 2 are correct. No need to clarify. 3, my child is not at risk at all to have the disease or become a trait carrier since we don't transmit the disease. What did we say? If both couples are trait carriers, 25% chance of transmitting the disease, 50% chance of transmitting the trait. So we can consider number 3 as potentially the statement that needs to be clarified with the geneticist. But even if we are already making our conclusion, let's read through option number 4. Our child will eventually transmit the trait or the disease to our future grandchildren. Of course, whether the child will transmit the trait or the disease would depend to the future grandchildren, would depend on whether that child will marry a trait carrier or a disease carrier or someone without the trait. But whatever it is, there's always a chance, since the child is already a trait carrier or potentially a disease carrier, there's always a chance for the child to transmit the trait or the disease to their future grandchildren, depending on the status of the future partner of the child. So therefore, statement number 4 is also correct. So the best answer for this is actually your option number 3. My child is not at risk at all to have the disease or become a trait carrier since we don't transmit the disease. This requires further explanation from the geneticist. Okay, so let's discuss macular degeneration. So it's actually an eye disease affecting the central vision of people of the age of 50. So the peripheral vision is intact. It's the central vision that is affected. So you would expect people with macular degeneration to say that they have black spots in the middle of their visual field. Now, this is in sharp contrast to a client with glaucoma who would tell you about tunnel vision or loss of peripheral vision. So if there's a loss of peripheral vision, think about glaucoma. If there's a loss of central vision, think about macular degeneration. So in macular degeneration, central vision is affected while the peripheral vision is fine and intact. Now, what are the risk factors that could potentially lead to the development of macular degeneration? Now, take note, this condition is treatable, but it is not curable, which simply means whatever function is lost in the eye could no longer be brought back to its normal state. However, we can prevent the progression of the condition. So the risk factors includes those that are contained in the mnemonic show ID. It's like show your ID and use your eyes to check on it. So smoking, having family history of macular degeneration. So check if the parents had it. If the client is overweight, and if the client is white or Caucasian. So this is also common to those with increased blood pressure or those that have hypertension, and those whose diet are high in saturated fats. So we can say, noting that you have here smoking, increased blood pressure, diet high in saturated fats, this could be in part due to unhealthy lifestyle. And of course, you have there also risk factor identified, one of the risk factors identified, overweight. But we're not discounting the fact that this could also be associated with familial predisposition, as there could be family history related to the disease, and it could also be race related. So the common manifestations of macular degeneration include, number 1, we have blurred vision, and then you have LBC, low vision, blank spots, curvy or wavy lines. So if you get to ask the client what's the common disturbance that they would usually experience when they are describing the symptoms related to this condition, you would notice that they would usually complain about straight lines not looking straight. What they used to consider as a good visual field when they are exposed to straight lines would now appear curvy or wavy. Thus, the test that is usually done for this client would be your Amsler grid test. So the client is usually shown straight lines that crisscross, and then you have a dot in the middle, and you will have to ask the client to describe it. And eventually, this is the kind of description that they would talk about, that the lines are wavy, that they have a black spot in the middle, or the lines are curvy. Okay. So another test would be your fluorescent angiography. This involves injection of a dye, followed by the use of a camera to track where the dye would go. And usually, this dye would reveal any leak that occurs under the macula. We also have your optical coherence tomography, or OCT. It's a non-invasive procedure. All we have to tell the client is to look into a lens while the machine takes pictures. After that, the pictures are analyzed. And then we have your optical coherence tomography angiography that uses laser light reflection and OCT scanning, followed by the tracing of the blood flow through the eyes. And this would produce your 3D images. Okay, now treatment for macular degeneration includes the use of vitamins and minerals and antioxidants. Vitamins C and E would usually be given, zinc and copper. Now, these vitamins would help in the preservation of the eyesight, and it will delay the progression of the condition. On the other hand, your antioxidants would actually protect the cells from the damage caused by oxidation. So you have the drug zeaxanthin and, of course, lutein. And these are the drugs that are used for wet macular degeneration. We call them the antivascular endothelial growth factor. So what is the mechanism of action of these drugs? First and foremost, it prevents the formation of blood vessels that grow abnormally. And these blood vessels that grow abnormally eventually would leak beneath the macula. So these drugs, therefore, prevents the formation of new blood vessels that could adversely affect the macula. And you have here our examples. You have your faricimab, ranibizumab, aflibercept, and bevacizumab. So pay particular attention on the suffixes, zumabs, ranibizumab, bevacizumab. So these are drugs for wet macular degeneration. I'd also like to highlight one important thing. Now, if you are given a case related to age-related macular degeneration or macular degeneration, you have to focus on the type, because a client with dry macular degeneration should be referred to an optometrist. An optometrist is a doctor of optometry primarily tasked to adjust your lenses in your eyeglasses, and at the same time, they can treat eye conditions, but usually they can't perform surgical interventions. For clients with wet macular degeneration, initially you refer them to an optometrist and then eventually to an ophthalmologist. So an ophthalmologist is a doctor of medicine that has specialized in eye disorders. So they can treat all sorts of eye disorders and at the same time can perform surgical interventions. So once again, if you have dry macular degeneration, refer the client to an optometrist. For wet macular degeneration, initially to an optometrist and then to an ophthalmologist. And if they would need adjustment to activities of daily living brought about by their blurred vision, then they can be referred to an occupational therapist. So here's our case number 13, a 71-year-old white male. We have two risk factors there. You have a client about 50 years old, and of course, the client is Caucasian, white male, comes to the emergency department complaining of dark spots in his vision. You have another outstanding manifestation there associated with macular degeneration. He also tells the nurse the pedestrian lanes look wavy and curvy. There you go. That sort of, it completes the group of factors that we're looking for in order to arrive at an inference of what the client's condition is. So this has made crossing the streets a challenge for him. So the nurse should anticipate treatment for the client to include Is it one, myotics? Now, myotics, example would be pilocarpine. These drugs are given to clients with glaucoma and not macular degeneration. So mydriatics, these are the drugs that dilate the pupils. Example could be your atropine eye drops that are usually administered to both eyes before eye examination. Vitamin and mineral supplements, and of course, surgical extraction. Surgical extraction, this is actually an intervention for clients with, for example, tumor of the retina, or when the client is suffering from retinoblastoma. So the best answer is definitely number 3, vitamin and mineral supplements. This will help delay the progression of the condition and could help preserve the existing functions of the macula. So on to our topic today, HELLP syndrome. Now, HELLP syndrome, some experts say that it is a variant of preeclampsia. Some say that it could occur with preeclampsia, but there are certain cases in which HELLP syndrome occurs even without preeclampsia. Now, HELLP syndrome, the common characteristic of this condition is the presence of bleeding related to low platelets. However, we also have some other bleeding disorders in pregnancy, like disseminated intravascular coagulation. How do we differentiate HELLP syndrome from disseminated intravascular coagulation? First and foremost, pay particular attention to the fact that in both conditions, you have bleeding. However, it's the laboratory works that would tell us whether that's HELLP syndrome or disseminated intravascular coagulation. In HELLP syndrome, you have low platelets that is considered as related to the bleeding that's being suffered from by the client. In clients with disseminated intravascular coagulation, the laboratory works that characterizes the bleeding could be prolonged prothrombin time, prolonged activated partial thromboplastin time, and of course, your serum fibrinogen, okay, which could also be altered. Now, in clients with HELLP syndrome, your prothrombin time, your activated partial thromboplastin time, and the serum fibrinogen of the client, these are all normal. So these 3 diagnostic or laboratory data would enable you to differentiate HELLP syndrome from a client with disseminated intravascular coagulation. So HELLP syndrome is a complication of pregnancy that's characterized by have the mnemonic HELP, hemolysis, meaning there's RBC destruction, elevated liver enzymes, so elevated AST or ALT, and of course, low platelets. The normal platelet count would usually be from 150,000 to 450,000. For clients with HELLP syndrome that's so severe, the client could have platelet counts that could be less than 50,000, in which case spontaneous bleeding may occur. Okay, so HELLP syndrome typically occurs with preeclampsia. Now, once again, it typically occurs with preeclampsia. However, there are instances in which you have HELLP syndrome, but you don't have preeclampsia. So it does not necessarily mean that whenever a client has preeclampsia, HELLP syndrome is always present. It doesn't go that way. Okay, so HELLP syndrome is manifested by seizures. Seizures is actually one of the late occurring signs of HELLP syndrome. Pain is one of the most common early occurring signs of HELLP syndrome. So you have right upper quadrant abdominal pain that could be associated to the damage to the liver tissues, okay, edema and weight gain, nausea and vomiting, and of course, sometimes there could be episodes of nose bleeding and deep breathing pain that could be associated once again with the tissue changes in the lungs of the client. So HELLP syndrome is diagnosed with complete blood count, your liver function tests, and kidney function tests. So the only solution to treat HELP syndrome is through the delivery of the baby. So that's the only thing that could help treat HELP syndrome. So other interventions for HELP syndrome includes corticosteroid therapy. This is primarily done to promote fetal lung maturity in the baby. Your antihypertensives to address the elevated blood pressure that occurs in clients with HELP syndrome. That is also a feature of preeclampsia. So proteinuria and elevated blood pressure, which are features of preeclampsia, also occurs in HELP syndrome. And then, of course, magnesium sulfate that is given to manage the seizures of the client. And of course, blood transfusion, which are usually done for the client because of the low platelets. So the blood transfusions are done in order to address the problem related to bleeding brought about by the low platelets. Okay, so let's use what we learned in order to analyze a case. Here we go. A pregnant client has been found to have the following laboratory results. So elevated aspartate aminotransferase, that's your liver enzymes. Remember, HELP syndrome, you have hemolysis. And then the second criterion is elevated liver enzymes. Okay. And then in HELP, the last two letters pertain to low platelets. So you have it here, low platelets. So that should make you think about this condition having anything to do with HELP syndrome. And then the clincher, you have elevated lactase dehydrogenase. Now, the implication of an elevation of your lactase dehydrogenase is that it tells us that there's tissue damage, specifically tissue damage in the heart, the lungs, the liver, and the kidneys. So assessment reveals nausea, vomiting, swelling of the hands and feet, shortness of breath, and the characteristic bleeding. So let's move on and try to figure things out related to the question. Which of the following conditions should the nurse consider? So abruptio placenta, you have to note abdominal rigidity plus dark red vaginal bleeding. We don't have that in the case. Placenta previa, you have painless, bright red vaginal bleeding. Once again, we don't have that in the case. Then we're left with HELP syndrome and disseminated intravascular coagulation. What did we say? Okay, in clients with disseminated intravascular coagulation, the abnormalities would usually point out to the three diagnostic tests: prothrombin time, activated partial thrombopoietin time, and your fibrinogen levels. And those tests weren't mentioned in the case. So in this case, the most possible correct answer would be 3, HELP syndrome. On to our discussion. So when you speak of histoplasmosis, what are the things that you have to remember? So let's begin with a functional concept. Remember, a functional concept could be a word, a phrase, a sentence, or even an entire paragraph that gives you a sense of direction on how you should think when you see a specific condition, and it gives your mind a sense of direction on how to deconstruct the questions eventually. So let's begin. Histoplasmosis is caused by a fungus. It's called Histoplasma capsulatum. It is also called cave disease or spelunker's lung disease. Now, spelunkers are people who love to explore caves. So this is the reason why there are at least for histoplasmosis. Histoplasmosis is a fungus that's usually transmitted to humans when they inhale the soil or the bird manure or bat manure that they've been exposed to in caves. So which simply means that this is primarily transmitted through inhalation of the fungus. Okay, so it has no human-to-human transmission. Therefore, remember that we only need to implement, according to the Centers for Disease Control, your standard precautions, okay, when we take care of these types of patients. Now, pulmonary manifestations are the hallmark of histoplasmosis. Now, when you speak of pulmonary manifestations, we think of cough And since this is a form of an infection, it's a fungal infection, so you also have fever. Now, when you think of cough and fever, there's a very, very common pulmonary disease, and that's your tuberculosis. So it could be alike in terms of the signs and symptoms. However, you have to focus on the data that would tell you that the client could have been exposed to the fungus for you to be able to identify that it's histoplasmosis. So therefore, if the client has had a history of cave exploring or mountain climbing or going to areas where there is an increase in histoplasmosis, and eventually they develop fever and cough, chances are that could be related to your histoplasmosis. So manifestations of histoplasmosis can include, remember, histo, headache, increased temperature, fever, shortness of breath, and sweating. Now, this is very, very like your tuberculosis, tiredness, and then you have your observable bumps or rash on the lower legs, which could not be present in a client with tuberculosis. Now, in clients with histoplasmosis, they develop complications like hepatosplenomegaly or bleeding peptic ulcer. And if it goes into the central nervous system and eventually the bone marrow, the client could develop decreased red blood cells. So, which simply means the client could have anemia or even bone marrow suppression that could eventually increase the risk of the client to develop other types of infection as well. So the gold standard for the diagnosis of histoplasmosis involves culture isolation of the fungus involving either the urine. So you would be asked to either gather a urine specimen when the client is being screened, or sputum specimen, or even your bone marrow sample. So other tests include your biopsy, X-ray, CT scan, bronchoscopy, and of course your bronchoalveolar lavage, in which the lungs is actually washed, and the washing is usually used as the specimen for the identification of the presence of the fungus in the client's pulmonary system. Okay? So, treatment of histoplasmosis involves the use of antifungals like, remember, ICA, itraconazole, corticosteroids, and amphotericin B. Now, you have to remember the fact that since this is a fungal infection, unlike tuberculosis, your antibiotics won't work. And not all antifungal drugs could help the patient. Like, for example, ketoconazole is not indicated for the client because it has the potential to worsen the development of hepatotoxicity or hepatosplenomegaly in a client with histoplasmosis. So remember also that the infection can go away on its own even without treatment if the client has a healthy immune system. However, since histoplasmosis is one of the common opportunistic infections in clients who are immunocompromised or who are suffering from full-blown AIDS, it's important to note that if the client is HIV positive, then they need additional treatment. Okay, so let's apply what we just learned to our case number 11. A 37-year-old male comes to the emergency department due to cough and night sweats. Now, pay particular attention to the cough and night sweat. So this should give you a clue that this could be potentially either tuberculosis or histoplasmosis. Read through until the last letter of the case. On admission interview, he admits to have gone mountain climbing and exploring the Seneca Caverns in Bellevue, Ohio. Now take note, Ohio is one of the areas where histoplasmosis is usually affecting clients, especially those who love to explore the caves or your caverns, and they have a cavern system there where a lot of tourists would usually go there to explore it. So we now have that risk factor that could tell you that this could be histoplasmosis. So the client admits to being HIV positive. His current CD4 cell count is 100. Definitely that's very low. Usually clients who have healthy immune system could have a CD4 cell count from 800 to 1,000. When the CD4 cell count goes below 300. That would mean definitely that the client is developing immunosuppression. So, therefore, given the clue that the client has cough, the client has night sweats, the client has gone mountain climbing and exploring the Seneca Caverns, and of course, the client admits to being HIV positive, this should give you the clue that the client could be having histoplasmosis. So the question now is, which of the following medications is not used for treatment of histoplasmosis? The key word here is the word not. So itraconazole definitely is the antifungal that's used in the treatment of histoplasmosis. So is your amphotericin B, and of course your prednisone, but not your ketoconazole because it could potentially worsen hepatosplenomegaly or may cause hepatotoxicity in a client with histoplasmosis. So the answer definitely is number 4, ketoconazole. Why? Remember, once again, may potentially cause or it can potentially worsen hepatotoxicity or hepatosplenomegaly in a client who is suffering from histoplasmosis. Okay, now the first functional concept for SLE or systemic lupus erythematosus is that you have to know what causes it and what kind of condition it is. So SLE is a chronic autoimmune disease which can affect the skin, the joints, kidneys, and other organs. In a nutshell, it's a multi-system disease. Now, we also have a type of SLE that's drug-induced, and these 4 drugs could be associated with drug-induced SLE. And you have your quinine, anti-malarial drug, hydralazine, an antihypertensive, isoniazid or INH, anti-tuberculosis, and minocycline, a tetracycline antibiotic. So any of these 4 can potentially induce your SLE. So common manifestations of SLE include the following. So remember, SLE, skin lesions worsened by sun exposure. If you would notice the one on the photo, you would see rashes on both cheeks, and it's connected with the rashes also over the nose, okay, giving rise to a butterfly-shaped appearance of rashes. Now, just to differentiate, your slap cheek appearance of rashes on Fifth's disease, there's no connection over the bridge of the nose. That's for Fifth's disease. Slap cheek appearance of rashes, you have it on both sides of the cheek, but a few are, it's not really connected on the bridge of the nose. In SLE, your skin rashes or lesions are found on both cheeks and it's connected over the bridge of the nose. And then you have loss of memory and extreme fatigue with fever, joint pain, and headache. So anti-nuclear antibodies is a sensitive test for SLE. A combination of blood and urine test and physical examination can also help diagnose SLE. So treatment for SLE includes your non-steroidal anti-inflammatory agents like ibuprofen. Remember to give the medications always with meals. Immunosuppressants like azathioprine, your corticosteroids, methylprednisolone. Now, your immunosuppressants and corticosteroids may potentially increase the risk for infection. So the patient must be protected from that increased risk. And of course, your anti-malarial drugs, hydroxychloroquine. So it forms the code NICA. So for SLE, call NICA. So here's our case number 8. A 42-year-old male presented at the emergency department for joint pains. This is where it gets a little difficult because there are several conditions that are presented with joint pains like rheumatoid arthritis, okay? Urinalysis revealed a protein level of 3+. Once again, there are other conditions that could potentially cause increased protein in the urine, like for example, your nephrotic syndrome, acute glomerulonephritis. Okay, vital signs are temperature 36.2 degrees centigrade. That's normal. But the blood pressure, once again, is elevated. So you might be thinking about a possible kidney disease because you have protein in the urine plus an elevated blood pressure. However, take into consideration that the joint pains is what brought the client to the hospital. So physical examination reveals normal muscle strength and tone in the extremities and pitting edema in both legs. Now, the pitting edema could be associated with kidney impairment. So further assessment reveals rashes on both cheeks. That's where that specific pathognomonic sign that you have to look for is coming in. And over the bridge of the nose that occurred after a drug intake. And that's important to note. It occurred after a drug intake, so this could mean that this could be drug-induced SLE, okay? The nurse should ask the client about which of the following drugs related to the cause of the clinical manifestations presented on admission. So the case is asking you about the cause. It's not asking about the treatment. So ibuprofen is associated with treatment, okay? Your methylprednisolone is also associated with treatment. Azathioprine is also associated with treatment, but isoniazid is a drug that is associated with drug-induced SLE. So what could have caused the group of symptoms that affected the client? It is number 3, isoniazid. So I hope you learned from today's case study. So the first thing that you have to consider asking yourself when you are preparing for your next gen NCLEX would be, what do I need to study? And for you to be able to answer this, you need expert opinion, not the opinions of the false prophets of the NGN, which abound online, okay, during these days. So let's begin with our next generation NCLEX-RN case number 7. Okay. So we're going to talk about Wernicke-Korsakoff syndrome. It used to be that these two conditions are discussed separately. You have Wernicke's encephalopathy and Korsakoff syndrome. But since in most cases these two coexist, so it's important that we discuss it as two different conditions that coexist in clients with history of alcoholism. So Wernicke-Korsakoff syndrome is actually a complication of chronic alcohol use or abuse. So Wernicke-Korsakoff syndrome is a memory disorder due to a deficiency in thiamine or vitamin B1. Now, we usually get vitamin B1 from poultry products like pork. So what happens is, in the absence of thiamine, the body would eventually become malnourished because glucose will not be absorbed properly. So one of the important or significant functions of thiamine in the body is that it facilitates the absorption and metabolism of glucose, thereby enhancing our energy. So this deficiency also in thiamine would eventually lead to a memory disorder. And this could also be associated with our deficiency in glucose. We know for a fact that for our brain to function better, you need glucose. So Wernicke's encephalopathy is the acute phase of the disorder, while Korsakoff syndrome, characterized by amnesia, represents the chronic phase of the disorder. Therefore, if we talk about an early sign of the disorder, then that could be your Wernicke's encephalopathy. And if we talk about a late sign, then that could be your Korsakoff's syndrome. So what are the things that should alert us that a client is having Korsakoff syndrome? So it's characterized by RAP, retrograde amnesia, anterograde amnesia, and confabulation. So for clients with Wernicke's syndrome, they would usually suffer from, remember, COAT, okay? So confusion or confabulation, okay? And then they will have ophthalmoplegia or paralysis of the eye muscles. And then they eventually develop ataxia and thiamine deficiency. So interventions for Wernicke-Korsakoff syndrome include the following. Remember the code VINA, okay? So vitamin B1 tablets or injection, intravenous fluids, nutritional support, and of course, definitely abstinence from alcohol. In some other literatures, nutritional support would usually involve provision of additional calories and administration of glucose. Okay, so on to the application of these functional concepts. So let's begin discussion of case number 7. A 64-year-old woman was referred to the alcohol rehabilitation facility due to extensive cognitive problems. Neuropsychological assessment done on admission revealed global cognitive decline and memory impairment, including decreased attention span and loss of executive function. Now, if you're going to read through this case, it's actually quite difficult to decipher which condition the patient is suffering from, but there's one specific datum here that should give you the clue, and that is contained in the first sentence. The client was referred to the alcohol rehabilitation facility. So this could be associated with the substance abuse associated with the use of alcohol. So let's answer the question. Which of the following treatment should the nurse anticipate as the immediate intervention for the client? Now, notice that there could be one or two that are so close when you go through the options. So let's begin. Is it option 1, vitamin B1 injection? Option 2, high-calorie diet. Option 3, darkened room. Option 4, IV fluid infusion and glucose. Now, darkened room is a no-no. Definitely when a client is suffering from alcohol withdrawal syndrome, they would usually have hallucinations. So it's more important to assign them to a well-lit room or well-lighted room because they fear shadows because of their tendency to have visual hallucinations or tactile hallucinations. High-calorie diet may be essential, but it's not the immediate intervention. So we're left with options 1 and 4. Is it vitamin B1 injection or IV fluid infusion and glucose? Now, if we go back to the pathophysiology of the client's condition, we discussed early on that your thiamine is better absorbed if it's given by injection or by IV. However, between thiamine injection and IV fluid infusion with glucose, we need to address first the primary problem, because glucose will not be absorbed without if the client has a deficiency of vitamin B1. So we first have to administer the vitamin B1 in order to facilitate the absorption of glucose. So if we talk about which one is more immediate, then the answer would be definitely option 1. Vitamin B1 injection. Take note that your thiamine or vitamin B1 could either be given by injection or through an IV fluid infusion. So if the option in number 4 could have been stated IV fluid infusion and thiamine administration, that would have made it correct. But for this specific question, the correct answer is option 1. Now, on to our focus for this case discussion. And this is about borderline personality disorder. So let me first give you an overview what a personality disorder is. So let's remember that when we say personality disorder, this is a lifelong condition, and it's primarily characterized by rigid and inflexible patterns of functioning. So these are things that would not change. So it's either you live with them for the rest of your life, okay, in suffering, or leave them behind. But whatever decision you make, it's gonna put a toll on your emotional health. So make sure that you are ready to make that decision on whatever side you would want to take. Okay, so borderline personality disorder is characterized by pattern of unstable but intense relationships. So if you get to see people who are talking about how madly in love they are one time, and immediately thereafter, a couple of weeks after, a couple of months after, they're already bad-mouthing their partners. Now, this is not just true for their partners or love interests. This could also extend to their relationship with coworkers. So be careful when you meet a person who would always speak bad about the companies they've worked for in the past. chances are the company is not the problem, especially if it has a strong legacy and background. The problem is that person. If they have nothing good to say about their previous employers, the same will happen in the future, possibly because they have borderline personality disorder. So these people would love to play the victim role as if they were placed in a situation that they don't have any choice, but it's actually their interpretation of the events surrounding their situation that made them feel that they are isolated. So a client with borderline personality disorder is impulsive. So they do things impulsively without thinking about the possible repercussions or outcomes or results. So, and this could extend in terms of buying things or stuff for themselves. They could also be suicidal. And the most important feature is that they fear abandonment or separation. These are the people who would create stories when they feel that their partner is about to abandon them. It's the way they are, and we can't change that unless they go through a treatment and management of their behavior. So a client with borderline personality disorder may engage in dangerous behaviors like dangerous driving, gambling. They could be promiscuous. They engage in unsafe sex. Or they could be like manic clients. They spend beyond their means. Or they could engage in binge eating, drug misuse, or this is a very, very frequent finding of human resources managers related to clients with BPD. They sabotage success by suddenly quitting a good job. It's like they ask you to give them more jobs, and in the middle of it all, they quit and they leave you hanging there. Be careful when you have friends like this. They could be suffering from borderline personality disorder, especially so that these people are very manipulative, okay? They entice everyone in their circles to believe their frame of thought. And they do that by spending for snacks, spending for gifts. And you would notice that these are the people that every time there's an occasion in the office, they would usually take the time out to buy the latest gadget, flashy shirts, because they want to show everyone that if you are friends with them, you will enjoy the same privileges. That's how manipulative they are. Be careful. When a person begins talking nasty about their previous employer, that's a red flag. So let's apply what we just learned. Case number 6. A 27-year-old female is brought to the emergency department due to a self-inflicted wound on the wrist incurred after a heated argument with her boyfriend who verbalized that he needs space in their relationship. History reveals that this is the client's 3rd episode of self-harm related to admission to a hospital, and all were due to relationship issues. Okay, so there are some glaring indicators that this 27-year-old female, in our case, could be suffering from borderline personality disorder. One is you have self-inflicted wound. Second, you have a pattern of unstable relationships. And third is you get to see that the client's behavior has escalated, that has led to heated argument. So that could be the triggering point. Therefore, when we have clients like this, the priority intervention for clients with personality disorders would be to always maintain consistency. And we always need to set limits. Since they are manipulative, they should be always reminded with unit rules. And those rules should not be broken for them. So they should never be given special privileges. But make sure also that these clients with personality disorders would not just stick to the rules, but at the same time, they should only be assigned to one nurse so that they won't split the staff, because these people who are manipulative have a tendency to split the staff. What does that mean? So whenever they are with one staff, they talk about the other staff in a not so good way. So eventually all the staff would be quarreling with each other. They will have personal issues and they don't know why. It could be that you have either a coworker with a borderline personality disorder or a client with a borderline personality disorder. So let's move on to the question. The priority of the nurse is to, is it one, assist in the wound treatment of the client, two, refer the client to a clinical psychologist, three, establish a no self-harm contract, and four, initiate the implementation of dialectical behavioral therapy. Now, the implementation of dialectical behavioral therapy is implemented in order to empower the client to handle relationships properly. Now, assisting in the wound treatment of the client, although this could address a physiologic need, it is not the immediate concern. Refer the client to a clinical psychologist. Once again, referral is usually done when the client would manifest symptoms that requires the expertise of another member of the health team. And establishing a no self-harm contract would definitely prepare the client to address issues related to suicide. So a no self-harm contract is the other way of saying that you establish a therapeutic nurse-patient relationship. So the correct answer is option 3. So on to our first case, and this is going to be about peripheral artery disease. So I have some visuals here just to remind you of what could potentially happen when you have occlusion of a peripheral artery. So you would notice that in the first illustration, we have an area of the leg in which the blood vessel is obstructed, and the obstruction is caused by the accumulation of fats, and we call this arteriosclerosis, okay, atherosclerosis, and that leads to arteriosclerosis. Now, when you say atherosclerosis, that's the building of fatty plaques or cholesterol plaques that could potentially lead to the hardening of the artery. So from atherosclerosis, it leads to arteriosclerosis. And when there's now an obstruction of the blood vessel, definitely there's going to be poor blood circulation, and comes with it would be poor oxygenation in the area that could lead to necrosis. Now, notice that in clients with peripheral artery disease, there is no or minimal edema. So either you don't have edema or very minimal edema. So the main symptom that an artery is obstructed would be pulselessness or a diminished pulse. So you would also notice that in clients with arterial obstruction, the ulceration could be dry. So two things that you have to remember to differentiate arterial from venous obstruction. In arterial obstruction, you have minimal or no edema. In venous obstruction, you have edema. In arterial obstruction, you usually have dry skin ulceration, while in a client with venous obstruction, there's usually wet skin ulceration. Now, on to the other important aspects of today's case. So peripheral artery disease occurs when the arteries are narrowed, leading to decreased blood flow to the arms and the legs. In peripheral artery disease, the decreased blood flow to the legs lead to a symptom which we call claudication. Now, when you say there's intermittent claudication, there is pain that is worsened with prolonged walking and then relieved by 1 to 2 minutes of rest. So if you want to assess the occurrence of intermittent claudication, you simply just have to ask a patient to walk for a couple of minutes, and then when they begin to experience leg pain, ask them to take a seat and rest for 1 to 2 minutes. If the 1 to 2 minutes brief period of rest will relieve the pain, then that would tell you that the client could be having intermittent claudication. Take note of how to assess intermittent claudication. So peripheral artery disease is manifested by, I have here a code which I formed, pallor. Once again, that's a copyright and it is registered under the trademark of the Gapuz system. So pallor stands for P, painful cramping. That's intermittent claudication. A, absence of pulse or weak pulse in the legs or feet. L, leg numbness or the presence of tingling sensation. L, loss of hair on the legs or slow growth of toenails. So you could see hardening of the toenails or very, very minimal leg hair on the especially on the lower legs. Then observable changes in skin color. So there's pallor because of decreased blood circulation, and of course, recurrent trouble getting an erection. So it simply means it could also be associated with the diminished blood flow into the genitals. That's why there's a difficulty for the male client to have and sustain an erection, okay? So the ankle brachial index or ABI is a test to diagnose your peripheral artery disease. So ankle brachial index involves comparing the blood pressures in the ankle and the arm. The blood pressures are measured before and after walking on a treadmill for a couple of minutes. So they would note if there's any discrepancy in terms of the blood pressure at the ankles and the blood pressure at the brachial area, meaning the arm. So remember that the farther the body part from the heart, normally the higher the blood pressure is. So it should be that in a normal individual, the blood pressure in the lower extremities is usually higher than the blood pressure in the upper extremities. Now, the priority goals of care for a client with peripheral artery disease include, first and foremost, definitely the main symptom is intermittent claudication described as pain. So you have to decrease the pain. And second is to maintain the health of the arteries. Now, how do we deal with these goals of care? How do we achieve these goals of care? So we can achieve these goals primarily through the use of drugs, and the drugs for clients with peripheral artery disease given to achieve the priority goals of care include primarily to decrease the pain. You will have to give your cilostazol. So it's a drug that thins the blood and it widens the blood vessels. A common side effect would be headache and diarrhea. Or another alternative drug would be your pentoxifylline. Side effect would be gas, pain, dizziness, including nausea and vomiting. Now, pay particular attention to the fact that your cilostazol and pentoxifylline can thin the blood, and so therefore, if the client is taking blood thinners, you have to caution them that they have to clarify it with their physician, because taking these drugs for peripheral artery disease could potentially worsen their bleeding tendencies. We also need to remind them and ask them if they are taking herbal remedies such as ginkgo biloba or ginger, even ginseng or chamomile. These herbal remedies could potentially also worsen bleeding. So never take drugs that have a blood thinning characteristics with herbal remedies that could potentially worsen the bleeding tendency of a client. Second goal is to maintain the health of the arteries, and we begin with your anti-cholesterol agents, your statins like atorvastatin, lovastatin, simvastatin. Now take note that your statins are hepatotoxic. So these are best taken at dinner time, but you have to check your liver function test. And then, of course, aspirin, which is also a blood thinner, but it helps maintain the health of the arteries. Your clopidogrel, which has also a blood thinning effect, so it may also worsen the tendency of the client to bleed. And of course, your antihypertensives, which could promote vasodilation, thereby relaxing the blood vessels and promoting adequate circulation of blood in the area. Now, what should be the discharge instructions for clients with peripheral artery disease? So first, don't smoke, quit smoking, and then eat healthy, specifically low-fat diet to control the cholesterol so you can maintain the health of the blood vessels. Avoid over-the-counter cold remedies like Sudafed, Advil colds, as this may tighten the blood vessels and therefore can potentially worsen intermittent claudication. And then we have to tell our clients to regularly wash and dry the feet. They can apply moisturizers like your Aveeno lotion, but not in between toes, because the area in between toes when they are applied with a moisturizer is a good culture medium for bacterial growth. So that could potentially lead to complications. And 5, use well-fitting shoes with thick and dry socks, specifically your cotton socks. Those are very, very important things that we have to tell our clients. So once again, before we move on to our case for the day, let me share with you our passers from more than 30 countries worldwide who have experienced how it is to be under the Gapuz system. So here's our case number 1. A 35-year-old male who is a smoker since 17 seeks consult at the emergency room for leg pain that disturbs his sleep at night. Further assessment reveals that the pain is relieved by dangling the legs at the side of the bed and walking around the bed for brief periods. Now, pay particular attention to this. However, the pain has become increasingly bothersome and has not improved with walking lately. Let's analyze this. So initially, the pain is relieved by dangling the legs at the side of the bed because that helps in the circulation of blood in the area, and then walking around the bed for brief periods. So the brief periods of walk could actually relieve the pain, but eventually when you walk in terms of longer distances, so that could potentially now impair blood circulation, and that could make the pain worse. As it is stated in the last sentence, the pain has become increasingly bothersome and has not improved with walking lately. So the question related to case number 1 is, the nurse should anticipate treatment of the client to include phenylephrine, vasopressin, cyclomethazoline, or cilostazol. Now take note, phenylephrine, vasopressin, and cyclomethazoline all could potentially cause vasoconstriction. And so therefore, these drugs are not appropriate for the treatment of a client with peripheral arterial disease because they can worsen vasoconstriction of the arteries and could therefore worsen the symptoms of the condition. So the drug of choice would definitely be cilostazol because that thins the blood, and at the same time, it relaxes the blood vessel, leading to adequate blood circulation. So when there's adequate blood circulation, there's adequate oxygenation, and then eventually the pain will lessen. So the answer is actually number 4, cilostazol. Now, the second most important thing on our list now is actually liver cirrhosis. When we say liver cirrhosis, this happens when the liver becomes scarred and it becomes permanently damaged. So in essence, it would no longer be able to facilitate the excretion of metabolic waste products. It would not be able to manufacture your clotting factors. And so eventually, all of these waste products accumulate in the body, giving rise to your manifestations of liver cirrhosis. Now, what are the things that you have to look for you to be able to know that the patient could be suffering from liver cirrhosis? So jaundice, or when the whites of the eyes turn yellow, ascites or enlargement of the abdomen, clubbing of the fingers, as well as itchy skin because of the accumulation of bile salts. Now, the common causes of liver cirrhosis could be alcoholism, obesity, and of course, infection with the virus that causes hepatitis. So the priority goal of care for a client with liver cirrhosis is to slow the progression of the scar tissues in the liver, and that would entail modifying the client's diet. So the diet should be low sodium and low or moderate protein. You can avoid the blue cheese by all means. If you can avoid the cottage cheese, the Swiss cheese, the aged cheese, by all means, avoid it. And if in case you will be asked what would you need to know that would make you suspicious that the client's condition is progressing, well, when the patient exhibits flopping tremors or asterixis, that could mean the client has developed hepatic encephalopathy. And there's usually a drug that is given that's lactulose. It promotes the excretion of ammonia. However, common side effect of lactulose is diarrhea. Why? Because it changes the pH of the GIT. And any drug that changes the pH of the GIT would definitely cause diarrhea. Okay? Now, let me congratulate also our passers from all around the world who are increasing day by day, seconds by seconds, minute per minute. Okay? Now, the next one on our list is pelvic inflammatory disease. Now, clients with this condition are usually females who've had infection of the reproductive organs, meaning the uterus, fallopian tubes, and the ovaries. The most common cause related to your PID would be your gonorrhea and chlamydia. Now, what are the common risk factors? Well, those who are using intrauterine device are more at risk. This could also develop during menstruation or when there was abortion that was performed, or in clients having multiple sexual partners, and those who are below 25 years old who regularly douches. Because when you regularly douche, eventually you alkalinize the vaginal canal, which should maintain its acidity in order to fight off infection. So if you perform frequent douching, the vaginal canal may become alkaline, and that increases the risk for pelvic inflammatory disease. And of course, history of sexually transmitted infection will increase your pelvic inflammatory disease. How would you know that the client could be having pelvic inflammatory disease? Well, the patient could be having pelvic low abdominal pain, and then this pain comes with malodorous vaginal discharge. Or there could be unusual bleeding in between menses and painful sexual intercourse. And you will know that you have an infection when you develop fever, chills, and painful urination. Now, a potential complication of pelvic inflammatory disease could be strictures in the fallopian tube, and that could lead to ectopic pregnancy. So, it's very important that the appropriate treatment should be done ASAP when your client is suffering from pelvic inflammatory disease. Okay? So to pass the NGN, you have to learn how to navigate with technology. And here at the Gapuz system, we not only provide concepts to our learners the functional way, but we also teach them how to navigate technology through our technology-enhanced learning tools. Okay? In fact, I asked one of our recent passers this question: which part of our review helped you the most? And this is a response. The TOP, that's a test overview program, is a software that we're using for our comprehensive review. And of course, 311 refers to NCLEX 311, the QUICKFIX sessions. I attended the one from January 3 to 5 online, then repeated the recordings 3 times because you are given a recorded version. I repeatedly watched the pointers on YouTube, and most importantly, I put God first. The one phrase that kept lingering in my mind that you kept saying, I am next. That is powerful. So believe that you are next and you will be next. This time around, set number 37. Okay. So as I always say, the first question that we need to ask ourselves is, if you are preparing for your exam, what do we ask ourselves? Well, what do we need to study? First and foremost, you have to get an expert opinion. So, my first pick for this session would be hypokalemia. Now, remember, hypokalemia may not necessarily be asked as a separate concept in the test. it could be asked in relation to the administration of diuretics. Know for a fact that your hypokalemia could result from too much urine output because potassium is primarily excreted either through the bladder or through the bowel. So usage of diuretics and laxatives could increase the risk of the patient to develop hypokalemia. So when we say hypokalemia, low potassium levels. So the normal is 3.5 to 5.3, but the test will not actually ask you about these normal values. It will be provided. So what are the things then that you have to remember? You have to be able to interconnect the information that are provided in the test. Like for example, if the patient has diabetes insipidus, if the patient has diabetes mellitus, definitely the patient will have hypokalemia. So when you see a low potassium level, you may want to ask the patient if they are suffering from any of these conditions, meaning diabetes mellitus or diabetes insipidus. Or you can ask them if they are having diarrhea or vomiting. Vomiting associated with bulimia. Now, hypokalemia could also result from alcoholism and chronic kidney disease. Okay, now, if your patient has hypokalemia, always remember the functional concept that muscle weakness occurs in both hypokalemia and hyperkalemia. So if a patient comes in with muscle weakness, it's not going to give you a categorical answer as to whether the hypokalemia, the muscle weakness is associated with the hypokalemia or the hyperkalemia. So what are the 4 things that you have to see so that you can safely say that the patient is indeed having hypokalemia? Remember the code CAMP. Look for constipation, abdominal cramps, muscle weakness, and polyuria, palpitation, and polydipsia. If these 4 sets of symptoms are presented in a case, think about hypokalemia. So what ECG wave will you see in a patient with hypokalemia? Exaggerated U wave. But don't get me wrong, U wave is considered as part of the normal ECG wave. So when you have exaggerated U wave, then that's associated with hypokalemia. So when a patient is having hypokalemia, the priority is to provide oral replacement of potassium, monitor the client's ECG tracing, and the most important thing is serial monitoring of the client's potassium level. Now, on to our next concept. This time around, it's about glaucoma. Now, glaucoma is a group of diseases that could lead to increased intraocular pressure. So primarily, the common symptom would be blurring of vision. If this acute, it comes with eye pain, and then eventually tunnel vision develops. So it's as if you're looking through a tunnel, all the peripheral areas are dark, and the central area is the one that you are able to visualize, okay, from within a tunnel-like structure, okay? So when you try to look at the lights, there would usually be rainbow halos around the lights, and these common manifestations would help you identify that indeed the patient's condition is glaucoma. Now, it has a genetic basis, so it's not a surprise if one of the parents had glaucoma, and then eventually when the children grow old, potentially they could also develop it. So glaucoma is not curable, but there are treatments available to delay the damage into the eyes created by the increase in the ocular pressure. Example of the treatment would be administration of carbonic anhydrase inhibitors like acetazolamide. Okay, so a client with chronic glaucoma is considered stable, so you can delegate the client. Okay, next, I'd like to congratulate all our pastors who are increasing in number every day. So thank you for the trust. And of course, last but not the least, for this specific set of concepts would be delusions. Now, when you say delusions, it's a false belief that's not expected of a person's level of education. So this false belief is usually fixed, and this is related to the most severe form of psychosis, that's schizophrenia. It's also related to mood disorders, and you might be surprised, some clients with Parkinson's disease would usually have it. Now, your delusion is primarily treated with antipsychotics and antidepressants. However, pay particular attention to the fact that if your patient is not receiving an antipsychotic, we don't give them levodopa. Levodopa is an anti-Parkinsonian that is given in order to prevent pseudoparkinsonism, which can result if the patient's taking antipsychotics. But if a patient with schizophrenia is not taking antipsychotics, there is a chance that if they are given levodopa, levodopa may worsen delusions and hallucinations. Now, another type of therapy that could be implemented to a delusional patient could be cognitive behavioral therapy, in which the aim is primarily to change the patient's thought process. And since delusions could result from schizophrenia, and the schizophrenic client is a symptom bearer of a sick family, so family therapy is also indicated for delusional patients. Okay? Now, another advice I'd like to share with everyone who are subscribing to this channel would be the use of technology. It's very important that you have to learn how to navigate technology if you want to pass NGN.